So this is the way the heart normally sits in the chest. When you look at the front of the heart, you're actually seeing this is the right ventricle and this is the pulmonary outflow tract. This is the part of the right ventricle that goes into the pulmonary artery. This white area here, that's the pulmonary artery. Over here's the aorta. It's behind all this stuff because when the heart from the front, you're actually looking at the right ventricle. The left ventricle sits posterior to the right ventricle. The left ventricle is a lot thicker. So if you're looking from the front, you'll see the right ventricle here, and then you'll see the right ventricular outflow tract where it goes into the pulmonary artery. And the left ventricle is behind there, and it's much thicker. It's back here. We always draw it flat on the board, and we always draw them kind of equal, but in real life, it's not really that way. It actually, if we were to look at you're going to look from the patient's feet up to his chest, like here's the chest, here's the sternum, here's the backbone. Okay, so if you're looking at the heart from the feet looking toward the head, okay, you'll see something like the right ventricle is going to be real skinny. Now you got the way you're looking at the heart. Okay, the left ventricle is going to be almost round. It'll have a big fat muscle, and then the right ventricle is going to be skinnier. The wall of the left ventricle is pretty symmetrical and it's real thick. And the right ventricle, the wall is much thinner. And the right ventricle is more floppy because it's not the left ventricle is basically a big circle with a big circular muscle around it. The right ventricle is kind of tacked on. It's much skinnier. And actually, if there's no blood in it, it'll just fall flat. Whereas the left ventricle will stay round because the muscle is a big round circle. And if you cut through the heart, you will see this big, nice, fat, round circle in the left ventricle. And the right ventricle is just kind of almost like a flap that's added onto it. The muscle's not nearly as thick. The muscle here is about 3/4 of an inch. The muscle here is only about 1/4 of an inch. So a big difference between the muscle of the left ventricle and the muscle of the right ventricle. Why? Because this only has to generate about 15 to 20 millimeters of mercury. This has to generate 120 or even higher. This can actually generate up to 300 millimeters of mercury pressure if it has to. We don't want it to be that high, but I've seen systolic pressures over 300 for a few minutes. So you can this side has to be real strong because it generates 120 every heartbeat, whereas the right ventricle normally doesn't generate more than about 15 or 20. In fact, if this goes over 25, that's abnormal, called pulmonary hypertension. So the right ventricle's in front, the left ventricle's in back. That means if somebody gets a knife and sticks it right in here, if the knife goes shallow, it may not even go into the left ventricle. It'll normally go into the right ventricle first. And then if the knife is longer, then it'll make it into the left ventricle. Now, if you look over here, this little thing here is the right atria. And if you look at the right atria, there's a little ear. See the little ear part right there? Mm-hmm. Okay, that's the auricular appendage. That's where blood clots form in patients that have atrial fibrillation. Remember when we were talking about blood flow through the heart? Normally, blood is coming through the atria all the time, except during systole. So as soon as the heart starts to relax, as soon as the tricuspid valve opens, blood is going to be coming right into the heart from the superior and inferior vena cava. This is the superior vena cava. Inferior vena cava is down here, you can't see it. But blood just pours into the atria. It doesn't stop there, it just keeps going right into the right ventricle. Throughout diastole, blood is just pouring right through the atria and going right into the ventricle. The atria does not need to contract for the ventricle to fill. The only reason the atria contracts is just to kind of add just a little bit of extra blood to top it off, to take advantage of something called Frank starting effect. But most of the time, most of the blood goes right into the ventricle even before the atria contracts. So it's almost totally filled even before the atria contracts. And so this is constantly getting washed out and cleaned out. However, this part up here, it's not in the line of fire. Blood doesn't wash through that area. So if you look at the right ventricle, here's the right ventricle, and here's the atria, like this. The blood's flowing right through here into the right ventricle. Here's the tricuspid valve. Okay? So as long as this is contracting, blood just constantly gets washed out. If the atria starts fibrillating, and we'll talk about what that is later, but the atria doesn't do this anymore. It just sits there and quivers. When that happens, this area still gets washed out because blood's flowing through there all the time. But this area up here, this little thing right here, blood will get trapped in there, and a blood clot will form here. So patients that have atrial fibrillation have a tendency to have strokes. The reason they have strokes and pulmonary embolisms is because these little things attract blood clots, and there's one on the left also. And then if the atria starts contracting again, that blood clot will come out and get pumped. If it comes out of the right atria, it goes to the lungs, and then you get a pulmonary embolism. If it's over in the left atria, and the auricular appendage sticks out over here, that blood clot comes out, goes into the left ventricle, goes out into the aorta, and usually goes up to the brain, and the person has a stroke. That's why people with atrial fibrillation have stroke. The reason people with AFib take blood thinners is to prevent from getting a stroke because blood clots have formed in this. Okay, now here's the aortic arch. You can see up here the aortic arch, and it right up here it turns and starts going down the back. And then as it goes around the corner here, it goes back. It goes posterior, so it goes back toward the spine. It penetrates deep into the body and actually runs right along the spine. So the descending aorta is right next to the bodies of the spinous process. If you look at the anatomy of the arteries and veins coming into the chest, up here is the superior vena cava, and then up here you have an innominate vein, and then you have the jugular vein. The big one coming from the neck is the jugular vein, subclavian vein, brachiocephalic, and then you have the jugular vein on this side, subclavian vein on this side. If you open the chest, the lung will partially overhang the heart, and you'll only see like right in the middle of the heart, because the lung kind of sits over on top of it. So the pericardium is like this silver sac that the heart sets in. And when you first open the chest, let me see. Well, the pericardium is kind of silvery. Wherever you see these yellow areas, the yellow is fat, but that happens to be where the coronary arteries are embedded in these little fat aprons that hang down. So if you want to find the coronary arteries, just look in the middle of these little yellow streaks, because that's where the coronary arteries are. Now the coronary arteries come off of the aorta right here, just above the aortic valve. The right coronary artery comes off the aorta right behind the right atria, so you don't see it here. If you pull this little appendage up, then you could dig down and find the right coronary artery. The left coronary artery comes off the aorta, but in this picture you can't see it because it's behind the pulmonary artery. It would be right back over here. So it actually goes behind the pulmonary artery. And if you would have to lift up the left atrial appendage to find the left main. The left main divides into the left anterior descending. The left anterior descending comes right down the front of the heart. This is the LAD, or the left anterior descending, right here in this yellow fat area. It's right in the middle there. And then the circumflex goes over this way, and then it disappears because it goes around the side. Now, let's look at the inside of the heart, because this is really cool and important. This is the heart that's been cut in half, so you can see inside the heart. Now, if you look, the front of the heart, you're not looking at the front of the heart, it's over on here. But if you're looking here, you're looking basically the back half of the ventricles. This is the left atria up here. This is the left ventricle down here. This is what's called the left ventricular outflow tract. This is the path that takes blood through the aorta. This is the aorta here. This is the aortic valve right here. It's being chopped in half. Now remember on the board I drew the obstructive cardiomyopathy, where the muscle gets too fat and blocks the flow of blood coming out of the heart. Picture the septum here being enlarged. Picture this muscle here bulging way out like this. Because here's the left ventricular outflow tract. Here's inside the left ventricle. Blood has to go out of here and in through this valve out here. If this piece of the muscle here bulged way out like this, it would block the blood getting from here to here. And that's what I was talking about earlier. Now, this right here is the mitral valve. It's built just like a parachute. If you want to understand how heart valves work, picture a parachute. So you have the canvas, or the big part of the parachute, then you have the tether line, and then these tether lines are connected to bigger tether lines, and then that's connected to the person. Here's the top part of the parachute, the silvery part there. That's just like this part of the parachute up here. The parachute tether lines are called the cordia tendineae. These little, see the little lines here? They hold the valve just like cords would hold the parachute. Where this parachute anchors into bigger lines, these are actually, in the heart, these are actually muscles. These are called papillary muscles. So these are muscles right here. These are the papillary muscles. They are an extension of the heart muscle. So when the heart contracts, the papillary muscles contract too. And it's important that they do, because when the heart pumps blood, the blood actually wants to go back into the atria, but these valves will snap shut. And when these valves snap shut, what keeps them from leaking is the fact that these muscles contract and hold these tether lines and hold that from ballooning back into the atria. So now let me familiarize you. Okay, this is the valve itself. These are the cordia. These are the cordia here, and this is papillary muscle here. See how it's holding the cords. Papillary muscle. This one's these are papillary muscles. These little things here are called trabecula. They look like a bunch of little papillary muscles, but the inside of the heart looks like a bunch of worms. These are called trabecula. Looks like a big fishnet. This isn't a good example. Here's the valve, here's the cordia, here's the papillary muscles here. Now, since this is part of the myocardium, it gets blood flow from the coronary arteries just like the rest of the heart muscle. So suppose you have a heart attack. Let's say here's an artery feeding the heart muscle, and here's part of the branch of that feeding the papillary muscle. This has to have blood supply just like the heart muscle. If you block a heart artery and have a heart attack, maybe you're killing the heart down here, but you're also maybe killing the papillary muscle. When a muscle is first infarcted, when you first have a heart attack, there's a very vulnerable. The first 48 hours, this muscle gets real weak and can actually rupture. If you rupture through the whole heart muscle, you don't normally survive that, because what happens is you get a myocardial rupture, the heart bursts basically, and you get a pericardial tamponade and normally die. But what can happen is, even if the outside of the heart doesn't burst, the papillary muscle can rupture, and the papillary muscle tears in half. So what happens is, this piece takes a ride, and this papillary muscle just detaches, and now the whole anchor is just flapping in the breeze. So when the heart contracts, half of the valve is just kind of going back into the atria. It's kind of taking the strings for a ride. It's like if you cut half your parachute, or you went up here. If you went up here and just snap that muscle right through, everything that this cord is attached to would let go, and so this piece of the valve would just be flapping, and that would definitely cause a murmur. But anyway, that's very serious, because the person, if it's in the left ventricle, they go into pulmonary edema. Looks just like CHF. The way that you would know the difference in the field is, once you learn about heart murmurs, you can kind of tell the difference by the way the heart sounds, but that's way beyond where we are. But everybody understand how those valves work, because now we're going to talk about the semilunar valves, or the valves that go from the aortic valve and the pulmonary valve. The aortic valve and the pulmonary valve look very similar. They look like half moons. Now there's three of them, but the other one's out here, so it's hard to draw three of them in one plane. Okay, so here's this. It's a big circle, and there's three cusps. Let me show you what they look like, because it's better. It looks like a 3D. Okay, here's what it looks like from the top. And if you cut the artery open and you can see all three cusps side by side, it looks like this. But the way it looks in a real heart is like this. It's a circle. There's one cusp, the other cusp, the other cusp. Now you can tell that this is the aortic valve. Why? Because see the little holes here? That hole is where the right coronary artery comes off. That hole is where the left coronary artery comes off. This is the aortic valve right here. And you can see two of the three have a hole in the side. Now you can see this is the back of the heart, this is the front of the heart, so it's kind of backwards. But this is where the left main, and then the LAD and the circumflex come off. This is the other side where the right coronary artery comes off, right here. You can see here's the cusps. Now here's the pulmonary valve, looks just like it, but there's no holes in the side because there's no coronary arteries coming off of it. So these valves are structurally almost the same. The aortic valve is just a little bit more round. The pulmonary valve is a little squishier, but they basically look the same. They're both about the size of, slightly smaller than $50, slightly larger than a quarter. When the heart contracts, what causes S1, or the first heart sound? You actually don't hear the blood emptying. You hear valves snapping shut and valves opening, mainly snapping shut. Almost all the sound you hear in the heart is valves snapping shut. So which is the first, when the heart starts to contract, what's the first valves that snap shut? The tricuspid and the tricuspid and mitral valve will snap shut first. And so this is a combination of the mitral valve and tricuspid valve snapping shut. They snap shut about the same time normally. So when as soon as the pressure in the ventricles exceeds the pressure in the atria, remember the parachutes, the big parachutes will, and they'll snap shut. And that's S1. That's the first sound you hear is those valves snapping shut. And they do it about the same time. There's things that can affect that. We'll get that later, but they both snap shut about the same time. Then, as the pressure continues to rise, then the aortic valve and pulmonic valve will open. Both ventricles will eject their blood. One goes to the lungs, one goes to the body, as those valves are open. Now, when the heart starts to relax, then those two valves will snap shut as the blood tries to go backwards into the heart and shuts the valves. And that's S2. So this is the pulmonic and aortic valve snapping shut. And the heart sounds are almost always due to the valve snapping. Normal heart sounds are due to the valve snapping shut. Mitral and tricuspid snapping shut, pulmonary aortic valve snapping shut. I'm trying to picture these things going on. When it first squeezes, the big AV valves or the mitral and tricuspid valve snap shut. And then when the heart relaxes, the blood up here tries to go back in the heart and snaps those valves shut. So that's what you hear. Now, a systolic murmur, okay, if blood during systole is going through a narrow valve like the aortic valve, it's going to make all kinds of turbulence. If you're trying to shoot a lot of water, okay, take a garden hose. If water's going out the hose and the hose is smooth, it doesn't make much noise. But if you put your finger over the end of the hose, and it makes a lot of noise because it's creating turbulence. So now if the left ventricle is trying to pump blood through a narrow valve, the turbulence and the sound is going to be made during systole. But it's going to be made at the beginning of systole because that's when most of the blood is trying to get through the narrow. So if you look at the sounds made from a narrowed aortic valve, it's going to look like this. Here's S1, and then you'll have S1 is right here, a little teeny piece of S1. But then the murmur occurs early in systole, and that's when the blood is coming out through the aortic valve. But then near the end of systole, less blood is coming out and it gets quieter, and then you hear the other valve snap shut at S2. So aortic stenosis you're going to hear right at the beginning of systole. It's a very loud sound. It goes like that instead of bump, 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 bump. Because it goes and it's real loud, and it's loudest in the middle. This is called a diamond-shaped murmur because if you look at the sound waves, it's shaped like a diamond. So now when you hear the lub dub, lub dub, lub dub, that'll mean something. This is the right side of the heart. Okay, here's superior vena cava, inferior vena cava, right atria. You're looking at the tricuspid valve, which goes between the right atria and the right ventricle. Blood comes automatically through here and dumps into the right ventricle. Here's the tricuspid valve. Here's the leaflets, cordia, papillary muscles. Now, when the right ventricle contracts, this valve snaps shut. Pressure continues to rise. As soon as the pressure in the right ventricle exceeds the diastolic pressure in the pulmonary artery, the pulmonary valve will open. Right here, see the three semilunar valves? Okay. This will open up. Blood will be ejected from the right ventricle. This is called the pulmonary outflow tract. This is where the blood goes from the right ventricle toward the pulmonary valve. The pulmonary valve will open. It'll go through here and up into the pulmonary artery. And then the pulmonary artery, right above the heart, will branch out. One goes to the left lung, one goes to the right lung. So right above the pulmonary valve, pulmonary artery comes up. It goes, half goes to the left lung, half goes to the right lung. And it's the patient's writing that, that's why it's backwards. Where this divides is where something can happen. Now, I'm going to play you the actual sounds of these murmurs, and you'll see what it's really cool because you can tell what it sounds like. Hear that harshness at the beginning? It's not love dub, it's vroom. Oh, it's even showing you a picture of it. Cool. See how that valve right there is not closed? It's not opening all the way? See how that one's opening all the way, now it's not opening all the way? That was helpful. Now, I will do aortic insufficiency, which is diastolic, and then I'll quit. Because now this is a diastolic murmur. Oh, this is the same company. It'll probably be here. Now, here's all during diastole. Can you hear that?
Yeah, it doesn't stop doing it.
Yeah.
It's during diastole, not systole. See, now it doesn't shut all the way. See, the hole is there during when it's supposed to shut. See, when that one shuts, that one's still open.
So the systole sound is correct, and that's how it should
The
be.
systole sound is normal in that one, although they could have made the systole a little quieter because it kind of clouded the issue. But in aortic insufficiency, the whole murmur is only during diastole. It's bump, boom, bump, boom. Now, let's review the coronary artery anatomy. Here's the aorta, and here is the left main coming off of the aortic valve, just above the aortic valve. Here is the right coronary artery coming off just above the aortic valve. These come off of the cusps of the aortic valve called the sinus of Valsalva. Here's the aorta, here's the aortic valve. I've only drawn 2 of the 3 cusps because the other one's out here. You have a hole over here and a hole over here. Over here you have the left main, and then it divides. Over here you have the right. You must know the anatomy of the coronary arteries. You must know that. This little piece here is called the left main. It's before the bifurcation. After the bifurcation, you have the left anterior descending, then you have the left circumflex. The left anterior descending comes right down the front of the heart. The circumflex goes around. Here's the left anterior descending coming down here. Here's the left main. They just call it the left coronary artery. Cardiology is called the left main because the left main feeds both the LAD and the circumflex. Like I told you earlier, at least 3 people in this class have an extra one that comes out the middle called the ramus intermedius right here. If you have 3, that middle one's called the ramus. Not everybody has that, but the ramus would come right in the middle if you had it. About 20% of the population has that. So some of you have a ramus. This is the right coronary artery. It comes right between the left atrium and between the right atrium and the right ventricle, and then it comes around back and goes down to the back and bottom of the heart. It feeds the bottom of the heart, which is called the inferior wall. So the right coronary artery feeds the inferior wall. These terms will be very common to you. When you get to cardiology, you'll have to know an anterior wall, an inferior wall, a lateral wall, posterior wall. So the right coronary artery feeds the inferior wall in just about everybody. The left anterior descending feeds the anterior wall. And the reason that's so important is because this is the most dangerous of all. If you block the LAD, that's the most dangerous. So if you have a heart attack affecting this artery, it's called the widowmaker. Because if you block the LAD way up high, the chances of surviving that are much less than if you block one of the other ones. If you look at the back, the right coronary artery goes down the back of the heart and forms the PDA. The circumflex feeds the lateral wall. The lateral wall is the side. This is the lateral wall over here. This is the anterior wall. This is the inferior wall. And the posterior is the back of the heart. That's called the coronary sinus. Veins tend to be big. If you look at, you see varicose veins, they can be as big as 3 of your fingers put together. Veins are very thin walled, they can get real big. In the heart, all the coronary veins come together right here, and this is called the coronary sinus. This empties into the right atria. When we study arrhythmias, you're going to hear the coronary sinus a lot because the anatomy of the right atria has so much to do with arrhythmias. You got to know these. You know the left main. It normally only goes about at the most a ½ inch before it divides. And then the LAD goes down the front. CERT goes around to the left lateral wall. Some people have the ramus, some people don't. Don't worry about that. But if you see an extra vein there, you know it's called the ramus. And then you see the right coronary artery goes around and then back down to the bottom. You'll need to know the right coronary feeds the inferior wall, the posterior wall. The LAD feeds the anterior wall and the septum, a lot of the septum. Remember the muscle between the ventricles. That's why when you have an anterior heart attack, the septum will often go along with it because they're both fed by the LAD. Now, we're going to talk about the heart electrically a little bit. Now, we've opened up the right atria and we've opened up the right ventricle. You're only looking at the right atria and right ventricle. You're not looking at anything on the left right now. This is where a lot of the important stuff happens. It's called the sinoatrial node, or SA node. This is the piece of tissue that initiates electrical impulses most of the time in most people. If I were to do an EKG on you right now, you would see something like this. Now, right about here in the cardiac cycle, right before the P wave, this is called the P wave. This is called the QRS complex. It's called the T wave. Right before the P wave on the EKG, this piece of tissue right here initiates an action potential. It starts an electrical spark. And the reason it does that is because those tissues leak sodium. And when sodium starts leaking into the cell, when it reaches a certain point called the threshold potential, the gates in the wall, sodium gates, open up and sodium rushes into the cell real fast. And when that sodium rushes in real fast, it starts an electrical spark. That electrical spark is conducted from cell to cell to cell to cell to cell through the entire heart. Once the electrical spark starts, it will continue to travel through the entire heart as long as everything's working good. So then it starts here, it travels through the atria. Now, if you notice, there's three green areas here. They call these the intranodal pathways. You know, it's very controversial for a long time. They really don't exist as nerves. When the atria is developing in the embryo or the embryonic stage, the muscle fibers grow in these pathways. And so if you have a muscle here and another muscle here and another muscle here, it's easier for electricity to travel this way than crossways because that's just the way the muscles form. So electricity will travel the length of a muscle easier than going this way from this muscle to this muscle. That's just the way it is. It's easy. If you get a rope and you make a wave down the rope, the wave will go the length of the rope much easier than go transfer down. So electricity goes through the way the muscles grow faster than across the muscles. So if you look at embryonic development of the atrial muscle, it tends to occur in three big fibrous loops. So electricity travels faster in these three areas of the atria than other areas. So it was assumed a long time ago that there's actually special nerves that made it do that. Probably not. But there is something called Bachmann's bundle, that one of these pathways is where the electricity travels from the right atria into the left atria, and there's a special muscular connection where these two atria touch each other, and that's called Bachmann's bundle, and that's important because that's the main way that electricity travels fast between the right atria and the left atria. The AV node sits right, remember a minute ago we talked about the coronary sinus, that big blue vein coming into the heart? Okay, if you look at the right atria, the veins bring the unoxygenated blood from the heart muscle back to the right atria, and they dump it into the right atria in a hole right there called the coronary sinus. Now this is deoxygenated blood, venous blood, so it makes sense it comes into the right atria because that's where all the other deoxygenated blood from the body comes into, and then it just goes to get circulated. So that's why the heart's set up that way. But that's a very important anatomical structure because the electrical conduction system of the heart is such that the AV node sits right next to the coronary sinus. Because there's a hole here, electricity cannot cross that hole because there's no muscle there, it's a hole. So when electricity coming from up here gets down here, half of it has to go that way, half of it has to go that way. So electricity is divided, and part of the electricity has to go on this side of the hole, part of the electricity has to go on that side of the hole. And that causes certain types of arrhythmias under certain circumstances. Now, if you look down here, where the vena cava come in, there's another hole. Where this vena cava comes in, there's another hole. Electricity can't go through where there's no muscle. There's no muscle there, that's a hole. There's a blood vessel coming out there. So now when the electricity starts here and it's spread out, when the electricity gets to that, it can't go through there, there's a hole there. So the electricity has to go around the hole, right? Make sense? And since the electricity has to go around these structures, that is what causes most arrhythmias. It has to do with the way electricity is conducted around anatomical or physiologic obstructions. And it causes something called reentry, where the electricity, during that phase, it may not be able to go this way, and so it goes the other way. By the time it gets back, then this area is ready, and it starts spinning in a circle. These circles can occur in many different parts of the heart. They can occur if the circle starts spinning here, it's called AVNRT, which you all call SVT. That happens right here. If the electricity starts going around the whole atria in a big circle, that's called atrial flutter. And if it happens, if you get a re-entry loop in the ventricle, it's called ventricular tachycardia. So these are very significant things, and when we get the EKGs, it's all going to make sense. Okay, so once the electricity gets to the AV node, the electricity coming into the AV node slows down. When the electricity starts out in the SA node, it's right here. When the electricity is going through the atria, it makes the P wave. That's the electricity going through the atria. But then you see there's a flat part here where nothing's happening. The electrical properties of the AV junction, or the tissue right outside the AV node, this area slows electricity down. And it does that on purpose. Remember I said that most of the ventricle fills automatically even before the atria contracts. The ventricle is about 80% filled or 90% filled. But then that atria contraction adds a little bit more, and it actually helps cardiac output because it gives the atrial kick that helps fill the ventricle, and because of Frank starting effect, makes the heart pump better. Remember, if the muscle's actually a little filled, it pumps better. This delays electricity in order to allow the ventricle to fill up. You do not want the atria and ventricle to contract at the same time because you lose the function of the atria. The atria is supposed to supply the last little amount of blood before the ventricle contracts. So you want it to go choo 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 choo. You don't want them going at the same time. So the electricity is slowed down there just enough to where these can finish filling, and then when the atria contracts, it puts a little bit more blood in, and then you get the Frank starting effect, and the heart's more efficient. So this area conducts electricity fairly slowly, and because of that, on the surface cardiogram, you don't see anything happening there. That's called the PR segment. Now, there is electricity going through the heart, but you don't see it on the EKG because it's such a small area that electricity does not make it to your cardiogram so you can see it, so it looks flat. Now, when the electricity finally gets into what they call the His-Purkinje system, the electricity goes real fast. It goes through the lower part of the AV node, the bundle of His, and the bundle branch is like a lightning bolt, and it just boom. So the electricity gets into there. If you look how electricity flows through the ventricle, so the electricity goes through these red lines real fast, and now the electricity, when it actually gets to the muscle itself, it's conducted through the muscle. The first place the electricity hits is usually right about here, just for anatomical reasons. That's the first place the electricity is usually going through the muscle. It's the endocardial surface of the left septum. So here's the first part of the heart to have the electrical wave go through. That's called depolarization. Depolarization is the process by which electricity flows through the heart muscle. And it's called that because if you put a little electrode in one muscle cell, the cells become polarized. They set up an ionic difference between the inside and outside. So there's an electrical potential. When the electricity flows and that sodium rushes in, that depolarizes them, and then the ions rush in the opposite direction, and that's the electrical spark coming through. And so that's the first part that you see it. And then like a hundredth of a second later, you'll see it coming see it coming like this. So then the endocardial surface of both ventricles will depolarize about the same time. And then finally, the entire heart will depolarize. The last part of the heart to depolarize is normally the left lateral part of the left ventricle because it's fatter. And so electricity goes through the right ventricle faster because it's skinnier, it doesn't take as long. So up here on the left side is usually the last part of the heart the electricity goes through. Now, before the next heartbeat can come, it has to reverse everything because now the ions are all in the wrong place. So the sodium-potassium pump in the cells has to reverse it. It has to recreate an electrical potential across the cell membrane. So the sodium and potassium reverse, they pump the opposite directions. The cell gets ready for the next beat. That's called repolarization, and you can also see that on the EKG. It's called a T wave. So the electrical wave going through the heart makes it contract, so here it's squeezing, and then during the T wave it relaxes, and then it stays relaxed until the next depolarization wave comes through. This is just the ventricles. We're not about to talk ventricles. Fibrillation is chaotic electrical activity caused by numerous ectopic pacemaker cells firing chaotically. In other words, they're saying that all of these got irritated or anxious or pissed off or whatever, and now they're all trying to be pacemaker cells. They're all trying to initiate action potentials. Total hogwash. It's been hogwash when they came out with it. It's hogwash now. And probably 90% of EKG books will still have this diagram. That is not what fibrillation is. Here's what fibrillation is. Now you have to follow it in a step-by-step sequence here. Let's say here's a piece of muscle. We're gonna watch this depolarization wave. It starts here. This is the electrical wave spreading out, right? So it's going like this. Let's say you have an area here that's ischemic. They have a blocked artery, they might be having a heart attack, or this area of heart muscle does not get as good a blood flow. That affects the rate at which the muscle can conduct electricity it affects the rate at which it depolarizes, it affects the rate at which it repolarizes. And catecholamines, epinephrine, norepinephrine, they also affect the rate of conduction velocity. So all of these hormones affect how fast electricity flows through the heart muscle. So now we're going to start an electrical wave here, and we're going to watch it get bigger. Now watch, when it gets to this area, something weird happens. It doesn't go through this area as fast because when the electrical impulse gets here, that area is not ready to accept the electricity right then. It's not dead. It'll accept it in another couple milliseconds, but when the electricity first gets here, it kind of has to go around it. Now, at some point when the electricity comes over here, let's say that that's the point at which this area is now ready to accept the electricity. Now, electricity has already gone through here, but it hasn't gone, electricity has not gone through this area yet, because when it got here, it couldn't go through, so it had to go around it. But now the electricity is over here, and it goes into there. And it travels through here, right? Now, what happens when this electrical wave gets to here? Electricity just went through there, right? So now, when it gets here, it has to go this way. And here, it has to go this way. So we started out with one electrical wave, now we have 4. Because it had to go around this, and then when it got over here, it had to re-enter this area. Now as the electricity goes through there, when it gets here, it can't go here because it's just depolarized. So now it has to divide and go around. So now we have electrical waves going through here. Because this was ischemic, and because this conducts electricity at a slower rate, electricity will travel through this area more slowly. So by the time electricity gets over here and starts to divide again, now this area over here may be ready to accept another electrical impulse, right? So now the electricity here comes back into here. Now as it comes around here, this area just depolarized, and now it divides again. And this happens over and over and over, and it never quits. So what happens is, instead of an organized electrical wave, it'll go into an area, it'll come back in the other side, it'll hit, divide, and what was one electrical wave becomes 2, 4, 6, 18, 24, 38, 120. Now electricity is going like this. And electricity is constantly trying to find a route, and it hits a piece of refractory tissue, it divides and goes in both directions. That's leaving a refractory area. And so electricity is constantly re-entering new areas, leaving a trail of refractoriness, and if the muscle's fat enough, the muscle's big enough, this will never stop. The only way you can stop it is to shock the whole thing with electricity and let it start over. This has nothing to do with automaticity or ectopic focuses. It's a conduction pattern called fibrillation. That's what all fibrillation is. Fibrillation is not a bunch of pacemaker cells firing. It's an abnormal conduction pattern due to one electrical wave becoming divided and redivided and redivided. But before it can die out, it keeps re-entering and re-entering and re-entering because this conduction pattern constantly changes. If it's in the ventricle, it causes sudden death. If it's in the atria, it causes other problems, but it doesn't cause sudden death because that's not the pumping chambers. If it's in the atria, it causes the atria just to quiver. And then they can get blood clots and they have to be on blood thinners and stuff. If it happens in the atria, you have so many of these electrical waves running around that the heart rate can often be too fast until you get the medicine to slow it down. But then once it's slowed down, they can survive fine with it as long as you prevent them from getting blood clots. If it happens in the ventricle, they're in cardiac arrest the minute it happens. If the ventricle does this, you're dead meat unless you shock them.